Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. This is Samih Odhaib, an adult endocrinologist and diabetologist from Iraq. Thanks to DART for this great opportunity to present our study, the study on assessment of the fasting eligibility for individuals with diabetic foot ulcers during fasting in Ramadan, the Safe Fast study. We have no conflict of interest regarding this study, and let's go to the introduction and background. There is assessing fasting eligibility for high-risk individuals with diabetic foot ulcer is critical due to a glycemic fluctuation and impaired wound healing. Some patients fasted despite the medical advice, endangering their health. That's why we have this study to evaluate 3,236 patients with diabetic foot ulcers with varying Wagner grades at our center from the years 2021 to 2024 for Ramadan fasting eligibility using the clinical history, diet risk stratification score, and lab test. We also gave the tailored fasting advice for every patient with compliance monitored across the pre-Ramadan period and Ramadan and post-Ramadan visits. So we examine all patients who came to our center during these 3 years. Let's get the results. We have 3,236 individuals with varying degrees of diabetic foot ulcers with a male to female ratio nearly equal. They were married in about 94% of individuals. Mainly, they are of type 2 diabetes in 99% of the cases, with duration of diabetes of 13 plus minus 6, and those with more than 10 years of diabetes in about 67% of cases. The age and mostly in their productive age in about 59 plus minus 11 years, and the BMI of the cohort was in the obesity ranges mainly, as you can see, with the about 78% of the cases in the obesity ranges. The hypertension was present in about 61% of the cases with the elevated blood pressure ranges, and wheelchaired 3% of the cases, patients with stroke 5% of the cases, and those with different ischemic heart disease in 10% of the cases. Patients with retinopathy represent 14% of the cohort, with CKD 16% of the cohort. Unfortunately, we have 5% of the cases with different grades of Charcot foot and those with different degrees of amputations in about 10% of the cohort. As you can see from this table, that the glycemic ranges mainly lies in the uncontrolled ranges with the hemoglobin A1C, which is the standard for care for in our center, in about 10 plus minus 2.6 with a range of 5 to 19, which is very high range for hemoglobin A1C. And even the lipid profile was uncontrolled in the majority of patients. For diabetic foot ulcer grading, we have the Wagner grades. The first grade 1, 2, and 3 represent the non-gangrenous ulcer, while grade 4 and 5 represent the gangrenous ulcer. For Wagner grades for this cohort, we can see that 51% of the cases in the grade 1, grade 2 represent about 36%, grade 3 in about 10%. This is non-gangrenous, while 3% of the cases in the gangrenous ranges of grade 4 and grade 5. The injectable therapies for the cohort, mainly with insulin therapy. The insulin duration for 63% of the individuals who use injectable therapies was 6.6 plus minus 4, with a range of 1 year to 34 years. As you can see from this figure, that the rapid-acting human insulin was used in 34% of the cases, 40% with premixed insulin, NBH, and about 14%. The analogs somewhat is lower in 13%, and for long-acting, 7.2 for rapid-acting, and intermediate-acting in only 5%. There was 21 only patients on GLP-1 receptor agonist. The other modality is the oral anti-diabetic drugs, that 83% of the cases received different OIDs, with only 27% of the patients had only OID with never on insulin. Glucophage represents the mainstay of the treatment in about 81% of the cases, DPP-4 inhibitors in about 26%, SGLT2 inhibitors in 14%, SUs in the form of gliclazide and glimepiride and glibenclamide in 14% of the cases, TZD in the form of pioglitazone in 9%, and glinides in 0.4% in the minority. For that risk stratification, which is the main concern here, is that patients with high risk represent the majority in about 78% of the cases were in the high risk, while moderate risk in 18% and the low risk, which was a minority of 4%. A mean DAR risk score for the cohort is 9.5 plus minus 4, with a range from 0 to 26.5, which is very high range. Now let's come to the for those patients who choose to fast different duration in Ramadan, and astonishingly that there was 702 patients fasted different duration in Ramadan. Number of individuals who fasted different duration in Ramadan was 21%, 21.7% of the cases. Majority were type 2 diabetes, with only one patient with type 1 diabetes choose to fast. The male to female ratio in the cohort who fasted was also nearly similar, and those with that risk categories who choose to fast, mainly from high risk category in about 45% of the cases. You can I will remind you that the high risk score represent about 70% of the cases in the previous cohort, but those who choose to fast mainly 44.6%, moderate risk in 43%, and the low risk about 12.5%. The mean DAR risk score for those who fast is not so different from that of the overall cohort, and it was 6.7 plus minus 3. The duration of fasting was somewhat different from those for the individuals. Those who choose to fast completely all Ramadan was 61%, fasted part of Ramadan 21 to 25 days, only 18%, and those who fasted half of Ramadan were 5%, and fasted 11 to 15 days 10%, fasted 6 to 10 days 3%, and fasted 1 to 5 days, which is minority of 3%. About 86% of the individuals fasted more than 50% of Ramadan. About 40% of individuals fasted many days before Ramadan. The median pre-Ramadan fasting days for those who fasted was about 6 plus minus 1, with range from 1 to 59, and those fasted in Rajab and Sha'ban. The mean duration for the patients who fasted was mean duration of diabetes for patients who fasted was 12 plus minus 5, with a range of 1 to 41 years. The duration for those more than 10 years of diabetes was 60%. Also, those who fasted, also in the majority, were obese, but in the obese ranges of mean, while the number was about 47% were in the obesity ranges, but the mean in the obesity range already. Also, the Wagner grades for them is grade 1 and grade 2 and 3, which represent the non-gangrenous. In grade 1, 65%, grade 2, about 30%, and grade 3, about 4.6%. This is the non-gangrenous part, while, thanks God, there is no patients from grade 5 who choose to fast, which is gangrenous grade, and grade 4 only 4 patients. Also, the majority of our patients were having hypertension on different antihypertensive medication with their systolic blood pressure in the high ranges, wheelchaired 1.9%, stroke about 5%, and the ischemic heart disease in 6%, retinopathy in 7%, which is slightly lower than the previous cohort. The CKD is similar to the overall cohort in about 13%. Charcot in 2.4, and the patients with amputation who choose to fast was only 5%. Also, the glycemic control, as the previous cohort, the larger cohort, represent the hemoglobin A1C more than 9 in about 44% of the cases. Hemoglobin A1C was 7.5 to 9 in about 27% of the cases. Hemoglobin level in the controlled ranges only in about 30% of the cases. And this table represents that even those who fast and choose to fast, whether on our advice or against our advice, had very high ranges of the glycemic levels and very high ranges regarding their lipid profile. Types of diabetic therapeutic regime for those who fast, mainly on multiple daily mixed insulin in about 20% of the cases, basal bolus and insulin pump in about 6%, once daily mixed insulin, which was used in 39 patients. We didn't use this in our center at all, but the patients choose to stay on it. Basal insulin on 7%, gliclazide, MR, glimepiride, or ribaglinide in about 40%. Other therapies, not including SUs, was used in about 58% of the cases. Self-monitoring of blood glucose is the mainstay of our control, conducted as indicated in about 25% of the cases, while those who didn't choose to do any self-monitoring of blood glucose was about 8% of the cases. This leads us to the problem of hypoglycemia. We have no hypoglycemia in about 55% of the cases, hypoglycemia in 38% of the cases, and multiple weekly hypoglycemia in 6.7. This data for 699 patients, because we have 2 patients, elderly female with type 2 diabetes, had choose to fast, although their total DAR risk score is very high and DAR risk category of 3, and they have multiple comorbidities and total fasting days between 14 to 29 days. While those with recent severe hypoglycemia was an reproductive age male, choose to fast, although he's on insulin for the last 12 years, and had ischemic heart disease and retinopathy, and fasted 12 days, although against our advice. Those for microvascular disease, we found in about 28% of the cases. In unstable part, 3%, and stable part, 25%. Diabetic HHS and diabetic ketoacidosis was found in the last 3 months before Ramadan in 1 person, 67-year-old man with type 2 diabetes, while it was found in the last 12 months in 2 patients, 14-year-old male with type 2 diabetes and 25-year-old male with type 1 diabetes. The strange part that the friability and cognitive function assessment, that 22 individuals with diabetic foot ulcer, age more than 70-year-old, had fasted in Ramadan a mean duration of 22 plus minus 7 days, ranging from 4 to 30 days. They had no home support at all. We mean that they do not live alone. They live with their families, but their families did not know anything about the treatment of diabetes. For the work, highly intensive physical work in 6% of the cases, moderate intense physical work in 52% of the cases, no physical work at all in 42 patients, and they fasted different duration in Ramadan. Overall negative experience was experienced by 35% of the cases, and no negative or positive experience for the 65. And as you can imagine, that we choose to have 4 years of assessment, and many patients choose to fast in different years, but we didn't find any relationship between the overall negative experience or any experience regarding previous Ramadan. To wrap up, we have many results regarding this study, but we summarize it in that 22% of the cases with different diabetic foot ulcers grades fasted despite the medical advice, posing risk to their health. This leads us to the recommendation that we must adjust our DAR risk score in a form of modifying it to address the individual fasting intention, both during Ramadan and on other days. Enhancing guidance, overcome the current limitation of the DAR risk score by providing more robust advice for individuals with higher risk scores, incorporating longitudinal use of the modified risk score as a follow-up tool to monitor individuals over time for improving management, and individualization of care and emphasizing on the personalized care for the individuals with diabetic foot ulcer who intend to fast, considering their unique needs. We need a broader metrics to enhance risk model by incorporating factors like frailty, cognitive function, and wound healing metrics. And we must engage the community by collaborating with the religious leaders and clerks to promote health awareness, acceptance of medical advice, and exemption when necessary. And lastly, the multidisciplinary approach to strengthen the team communication protocol to ensure consistent and effective patient care. This is a summary of our lecture and our study, which had many, many results. And at the end, I must say that Bismillah ar-Rahman ar-Rahim, لا يكلف الله نفسا إلا وسعها, لها ما كسبت وعليها ما اكتسبت. صدق الله العظيم. Thank you very much. And thank you for this opportunity to present our study. Thank you very much.